My name is Sister Dr. Grace Nanyondo. I'm a gynecologist and obstetrician working with Ruwaga Hospital as the medical director. I'm glad to share with you knowledge about sickle cell in pregnancy today. Sickle cell disease is a condition where the normal hemoglobin, that part of blood that is supposed to be normal, comes out abnormal. It is an autosomal sickle cell disorder, autosomal disorder, whereby one of the amino acids, the valine, the glutamic acid is replaced by valine. And instead of having a normal red blood cell, which is round, now you have an oval red blood cell, where when conditions of the body change, like extreme hot or heat, extreme dryness, extreme coldness, for them, they adapt to that condition by becoming extremely long, and they become long without going back, irreversibly long, such that when they are passing through thin blood vessels, they injure the blood vessels, they get trapped on the walls of the blood cells, they get sequestrated in the spleen. In the spleen is where the blood is cleaned. So it gets sequestrated. The cells are captured from there and they all congest there. So you end up having few circulating red blood cells, and their ability to carry oxygen is totally inhibited. They carry little oxygen, causing painful crises, the leg, the abdomen, the head, the chest, the stroke, the anemia, and name it. So these normal blood cells, for them, when they adapt to this condition, they are irreversible. They become long, but they're irreversible. When the condition change, then they become irreversible. Their oxygen carrying capacity is also not inhibited or affected at all. So this is the condition which I want to discuss. People who have it are usually born with it, and the burden is actually growing. And to make the matter worse, and because of improved medical care, many grow and reach reproductive age. And they also want to have children. So then the condition becomes complicated. That's where I want us to go and understand how do we care for these ones. However, the burden is significantly big, if I can take you back a little, that we have currently about 400,000 people affected with sickle cells. And 75% of these ones are living in sub-Saharan Africa. Tanzania is the leading country having people with sickle cells. Of course, since we are also part of the sub-Saharan Africa, Uganda is also having a good number of people living with sickle cells. So now, when they are planning to become pregnant, this is our starting point. They have grown, they have reached a reproductive age, and now they come to you, the gyne, the midwife, the doctor, the medical worker. What are you going to do? What do you need to know? This is what you need to know when they come close to you. You just know that when they come to you, you teach them right from when they are children, people who are taking care of children with sickle cells, that if they ever want to have children, they start with the preconception care. This care lasts for about 3 to 6 months. And this is where we prepare them to become pregnant. And what do we do during this time? We counsel them. We counsel them. The primary role is to counsel them. They need to know that sickle cell as a disease affects pregnancy, but also the pregnancy affects sickle cells. And how do these affect each other? Sickle cell affects pregnancy in that a woman who ever gets pregnant and has sickle cells, they have higher chances of complicated life, complicated pregnancy, higher chances of having gestational hypertension, preeclampsia, renal disease, retinal disease, pulmonary hypertension. They also have high chances of having frequent infections like chest infections, urinary tract infections, and meningococcal, that is meningitis, infection of the brain and the tube. So when you give them, that is how the disease, the pregnancy affects the disease. It complicates it in that way. So what do we do in this case? We screen them. We screen them for these conditions. We screen them for pulmonary hypertension by seeing a cardiologist. for an echo